Good afternoon. We're delighted to be with you again. This is the second part of our COVID series. And I am Dr. Tara Cortes. I'm the Executive Director of the Hartford Institute for Geriatric Nursing at NYU Myers College of Nursing, and I'm also a professor there at the college. Joining me this afternoon is Dr. Danielle Fox. Dr. Fox is an acute care nurse practitioner in the surgical ICU and transplant unit at NYU Langone. She is also certified as a critical care specialist, and she is an adjunct faculty member at the NYU Myers College of Nursing. We're going to discuss some of the experiences and wisdom that Danielle has gained from her time in the hospital, particularly during the months of March, April, May here in New York City, which were particularly difficult times in hospitals for nurses and families and patients. So Danielle, what is the important thing for families to know when their loved one is admitted to the hospital for COVID-19?
Hi, Tara. I think one of the most important things for patients and families to understand, if they are admitted to the hospital, that they will be restricted in terms of visitation with their families. So this in the beginning was very hard for patients and families to understand, because today most hospitals allow 24-hour visiting. So in the case during the pandemic, visiting hours is extremely restricted or non-existent at all. So with that being said, it's really important for families to understand this, and to understand that they will probably need to designate someone within the family to contact the hospital and to contact their family member, instead of having somebody, multiple family members calling every single day, especially if they're in the ICU.
But then how does the nurse support the patient and the family during this time when the patient is in the ICU?
So, and for the nurse, especially working with the families, number one, the nurse is kind of, I like to think, the liaison, in terms of their role between the patient and their families, and also the families and the other providers like nurse practitioners or physicians as well. So, obviously nurses provide the primary care 24 hours a day to the patient in the ICU. And, that could be depending on what level of care they are in, whether or not it's in acute or ICU, they're doing everything that they can for the patient, as depending on their level of care. But the big role that they do have for families is really being that liaison back and forth. I spent the majority of the time in the ICU. So most of our patients were ventilated, pretty much all of them were. So during that time, they weren't really able to talk to their family members. So they, looked to the nurses as well as providers like nurse practitioners and physicians to get information and updates on how their family was doing. So, nurses and nurse practitioners, we really worked to kind of give communication to family members about their loved ones that were sick.
Can you give us some examples of some people that you had cared for and how you brought together and assured the fact that the family and patient were having needed and necessary communication?
Sure. So, it was such a crazy time. And like I said, we really had the patient, it was really, especially how sick the patients were. We would really try the best that we could, to bring in the phones, like cell phones, to patients and have their family members talking to them, and things like that. Or we would just simply tell patients what their family members were saying. Especially during this time, patients were so sick. They were very heavily sedated and or paralyzed. So it was super hard, to kind of convey those messages, but we would try our best. On units where patients were not ventilated and were more coherent, FaceTime was a really popular way for patients and family members to connect, because, like I said, there was no visiting hours. So that was really important. And then NYU, we actually had at one point when things were really busy and we were also overwhelmed as providers with just taking care of patients and the high volume, we actually had specific liaisons that would talk with us and then talk with the family about updates on what was going on with the family, with the patients themselves. And they kind of served in that bubble to communicate what was going on. But what we really tried to do the most, and I think all of us tried to do, was a lot of the family members were so wonderful to us. We're so thankful and so appreciative. So we would, obviously tell their family member in whatever condition that they were that, your mom just called. We let them know that you're doing okay. Or your daughter just called. We let them know that you're doing okay. So, or your husband or your wife or whatever. And it's hard to tell. I don't, they were all, most of them were sedated, but that's some of the things that we would try to do.
You mentioned that patients were paralyzed, but when you say that, were they actually paralyzed?
Yeah, like we would, in order to ventilate them and to, get them in terms of normal gas exchange and like hemodynamically stable, we would have to paralyze and sedate them as if they were almost like undergoing a procedure, an operation. And we had to do this quite frequently in the COVID population because we really did have an extremely challenging time ventilating these patients, and typical maneuvers that we would use in the ICU setting for patients with acute respiratory distress syndrome, also known as ARDS, did not work for these patients for whatever reason because of the nature of the virus. So that was really challenging, and that was a really hard part of the care for these patients because they were completely paralyzed and sedated, and it was so important to get them like this to help them breathe at some points when patients were at their sickest.
Yes. What was the hardest thing for a nurse during this time?
I think the hardest thing taking care of patients wise was that it was not like taking care of patients in a normal circumstance. um, you know normally you're taught just to do be in the room as much as possible, but everything had to change at this point. So we were told to limit time in the room as much as possible to protect ourselves, patients, other staff members. So we really had to work to multitask things and to really kind of put things together and do as much as we could in the room when we were in the room. Definitely the donning PPE on and off was a lot. Just remembering to put everything on and off the right way was challenging. Um, and like I said, it's hard to see patients this sick, all the time. And the sheer volume of these patients was so massive, especially in late March and early April. It was very overwhelming for everyone, whether you were a brand new nurse or a seasoned nurse for 20 years, it didn't matter. It was something like no one has ever seen before. So I think the magnitude of that was very challenging for everyone involved.
I always think that there's protocols for everything in the ICU. There's protocols for everything in the emergency room. It dawns on me that in the time of COVID-19, there are no protocols. So how did nurses, doctors, and all of the other people involved in the care of patients know what to do? How did they figure out a protocol, which eventually, I guess, emerged from all of the patients you saw? Or did it? Maybe it didn't.
As we went along, we definitely learned a lot more about the patient population and how the disease worked. When you speak of protocols, you think someone comes in with acute coronary syndrome or an MI, they get started on heparin, they get aspirin, they get oxygen. So, in the beginning for these patients, they were all put on azithromycin, they got Plaquenil. And this was in the beginning before, this was in the very beginning before we all learned a lot of different things. And then we realized that patients were getting more blood clots. So then everyone started going on a heparin drip. And then we realized Plaquenil wasn't really working as much, or we weren't having, we weren't really having any difference in outcomes, whether they were on it or not. So it was it was always evolving. It was always adapting in terms of treatment for patients. And thinking about how we like managed everything, it was kind of just going, you were just going with how you were kind of just going with the flow at one point, because it happened so suddenly. The onset of the tsunami of patients that came in was so sudden, and we just were catching up at one point. Everyone was really doing their best, and like you said, yeah, protocols, all those things kind of did go out of the window at some point. All of us were doing the best that we could to maintain patient safety at, the highest level that we could possibly do. And obviously we had some restrictions at times. But we were always had the goal of patient care and safety in mind the entire time. But we were also under executive order, to do what we could to maintain staff safety as well as patient safety. So a lot of our regular things that we would do had to be altered to make up for these patients, the volume of patients that we were having, as well as the fact that we really were being advised not to stay in the room as much as possible, and to avoid these super spreading events and things that were aerolizing and stuff like that. So this was a challenge, or even when patients were arrested, you had to put on your PPE first before you went in the room. Normally someone's arresting you, run in the room, there's no questions asked about that. But in this situation, you really had to protect everybody that was involved in the care of the patient. So things were a little bit slower in terms of stuff like that. But it was really incredible to see everyone, new nurses, brand new nurses, and the most experienced nurses, brand new like everyone at every level, was really working together to maintain patient safety as much as we could.
This is now November. This recording is being made in November. It's a little more than 6 months after the first onset of this in the hospitals, the big surge back in the early spring. And I understand that people across the country, healthcare providers across the country, have learned from everyone else. So we in New York were kind of the beginning of it. I'd say us and also Washington, the state of Washington, we were kind of the beginners. And then as it has edged throughout the entire country today, it's been said that there's fewer patients on ventilators. There's different medications available. We all hear the vaccine is on the way. So what's different? What's different about the way in which care is given, and knowing that we in New York today and yesterday we're seeing a greater number, where our positivity rate is still one of the lowest in the countries, but we are creeping up. And I think the greater wisdom tells us we will be having more COVID-19 before this is over. What's going to be different about the care that nurses and physicians provide in the hospital the next time, as opposed to March and April?
Well, I think we know what to expect now. We know what COVID looks like now. So there have been so much advances in treatment since when we started, between the remdesivir and other treatments, that you've seen out in the media recently. And I think there's also less of a fear factor involved. When it first started, it was like, oh my God, we have to go to the COVID unit. We were so scared. We were scared for our lives. We were scared for our families' lives. But with the proper PPE, the majority of us were really able to stay safe and to not get sick. And I think that alone, helps you provide better care when you're not having that fear of getting exposed. So, and I think now organizations, especially here in Manhattan, are prepared. There is plans in place for surges in terms of supplies, staffing, and PPE, which was also an issue in the beginning. Um, so I think just overall being more prepared and understanding how the disease presents and progresses, we are like we're ready if we need to, be deployed again into or start COVID ICUs again within the Manhattan area. I feel like we're way more ready and prepared than we were back in March and April. We didn't know what was coming for us. Now we have like a strong idea of that, and I think we have a lot less fear going into it.
What are the most important aspects that nursing leadership can bring to the table during times of crisis? Because this was truly a crisis in the spring, and it could be a crisis again. So, what is important to have in your leadership at times like this?
I think for me and my NP leaders within the organization, and what I saw with my RN colleagues working with their leadership, just open communication was so important, even within the hospital organization as well, telling us every day what was really going on, with in terms of the numbers of the patients, in terms of how much supplies we had, like ventilators, how many patients were ventilated, things like that, just so that we knew what was actually going on. They also provided all of us with housing during that time, which was so huge. So just these levels of support, because that really helped decrease our stress in terms of like commuting, because that everyone was scared to commute, and also bringing it home to your family. So the fact that that kind of element was taken away from us was huge. And then post, or like even in the middle, they also offered us all different types of mental health resources too, because of a lot of us we're dealing with the trauma of going through a pandemic within the hospital setting, and also being separated from our families and our loved ones. So I think they did try to help us as much as they could, but the one of the most important things I think that in my organization we found out was that communication was so important, and being transparent about what was going on, so that again, there was so much fear associated with COVID in the beginning,
Yes.
and so now, like, that we're all on the same page about things, and even now we know how many patients are hospitalized. They give us updates and tell us how many patients have COVID throughout the campus or within the different campuses. So that's kind of that definitely helps.
It makes you feel like you're on the same page, and that I think makes nurses and everybody in the healthcare system, all of the people who are together, feel like they're part of a team. They're part of the greater whole, and all contributing. Well, as we are about to close, just talk a little bit about the important things for the public to know as this is surging across the country, and we're going into the depths of the winter across the country. What are the important things for the public to know about COVID-19 and protecting themselves, and also about needing hospitalization or not?
So to answer the first question, what do we need to know right now? It's basically the same thing that has been being said for a really long time, and that's to wear a mask, social distance, avoid close gatherings with people. It's very community spread. I don't, my professional opinion is that you're probably not going to get it at the grocery store if everybody's wearing a mask, but you may get it from your close group of family or friends that may not know they have it. So I think, it's very easy, especially after the summer, and, numbers were down and we had just come down off of lockdown. We got comfortable with our group of people, but, we shouldn't let our guard down, because the numbers are back up, and they're saying this strain is, less less deadly, or it's not making people as sick, but that is in, the younger population. People, older than 65 or with morbid conditions are still requiring hospitalizations at time. So, even though it's easy to get very comfortable, wear a mask and try to avoid, big groups or close gatherings of people. I think that's number one, the most important thing right now. A few months ago, it might have been different. It might have been just wear a mask and social distance, but now close gatherings, I think, are a big problem, especially in the tri-state area. In terms of hospital, if you require hospitalization, please remember about the visitation and that you will be restricted from talking with your family members or seeing your family members for quite some time until you're discharged. I think for older adults, it's super important to make sure that you have, a healthcare proxy or someone that is advocating for you, and that you designate that person just in case any difficult decisions need to be made. And, it doesn't mean life or death, but just anything about your care. I think that is so important, because so many patients we saw that, people didn't see this coming. So they didn't know they had to think about things like this. And even though it's scary, it really is important. I mean, it's important regularly, but especially when there's like this potential deadly virus going around, it's something to think about and to make sure that you have your health choices, figured out in your own mind, and you've expressed it to the people that you care about.
That's a very important closing message, that people do have their wishes known and documented, so that in case something happens, because we just don't know with COVID-19, you are protected by your own wishes. Well, Dr. Danielle Fox, thank you so much for being with us this afternoon. It was a pleasure talking with you, and we wish you well. And
Thank you.
hopefully you don't have another surge.
Hopefully, we'll see.
Thanks so much.
Stay safe.